All right, good morning, everyone. We are going to get started shortly. We have some folks joining now. Welcome to the Mental Health and Housing Online Forum. As you're joining us, just a few housekeeping things that I'll repeat a couple of times. You can see us, but we cannot see you. You are a key part of the conversation this morning, though, so we hope that you will join us in the chat and let us know what you are interested in hearing today. We've got some experts from all across Arizona to talk about mental health and housing. We're really excited for this conversation today. Please be asking us questions throughout this forum. We will be having great conversation between these panelists, but we want to make sure that you are involved and asking all the questions that you have. So don't hesitate to pop into the chat and let us know what you would like to hear about this morning. So we'll give it just another moment to allow folks to join this online conversation about mental health and housing. Again, you can see us, but we cannot see you. If you want to pop into the chat and introduce yourself and say what you're interested in hearing about today, we will be monitoring the chat as we go. My name is Serena Unrein. I'm with the Arizona Partnership for Healthy Communities. We are going to go ahead and get started and have our panelists introduce themselves. Quickly, a couple of housekeeping notes. The Arizona Partnership for Healthy Communities is really pleased to co-host this webinar today along with our friends at the Arizona Housing Coalition. We think these online discussions are really important to foster these cross-sector conversations about what allows for health and well-being and stable, affordable housing for all in Arizona. So we're really excited to have you joining us today. And we're really interested in your feedback. So if you are interested in having more of these conversations, please don't hesitate to reach out to either the Arizona Housing Coalition or the Partnership for Healthy Communities and let us know what else we can be discussing, especially in these online virtual conversations. So again, a few things to note. You can see us, but we cannot see you. However, you are an important part of this conversation, so please don't hesitate to pop into the chat like so many of you are doing right now and let us know what you're interested in hearing about from these panelists. We'll be taking audience questions throughout the online forum, so don't hesitate to add your comments, add your questions in the chat box today. We are recording this forum. We will be sending out a link to everyone who's registered. So if you want to revisit this conversation or share it with your colleagues, you will be getting a follow-up email with a link to the recording. First, I'd like to start by thanking our sponsors who really allow for these kinds of forums to happen. So I'd just like to really thank all of the supporting partners who are who have enabled all of this work to happen. One of our key sponsors at Mercy Care has a short video that I'd like to share now. And then we'll have you all get to meet your panelists. So again, thank you to Mercy Care and all of our sponsors for your support and in making these conversations possible. I'll now have our four panelists introduce themselves by sharing who they are and where they work. I'll go ahead and get started with Carrie.
Good morning. I'm Carrie, and I'm the Executive Director of the Brain Injury Alliance of Arizona. We're a statewide nonprofit and support professionals, caregivers, and survivors in every part of life after brain injury.
Great. Thanks for being here. Stefanie.
Good morning, everybody. I'm Stefanie Smith. I'm the Supportive Housing Supervisor at Native American Connections.
And Terrance.
Good morning. My name is Terrance Watkins. I'm the Housing Director for Community Partners, Inc., which is a division of Intermountain Centers for Human Development in Pima County.
Excellent. And last but not least, David.
Hi, David Bridge, Director of Housing Programs for Access. We have about 3,000 housing units through state funds, primarily for people determined SMI, but some seriously mentally ill, and also some for people who are with general mental health states. Thank you.
And just in case anyone's on the webinar who isn't familiar with Access, can you tell us what Access is?
Access is the Arizona State Medicaid plan. So the Arizona Healthcare Cost Containment System, which is Arizona's Medicaid program.
Great, thanks, David. All right, so first question for all of our panelists. How do you see mental health and housing being intertwined in your work? And we'll go in reverse order this time. So David, how do you see mental health and housing intertwined?
This is a major initiative right now for Access, and I think for healthcare programs nationwide, is this understanding that I have a graphic I forgot to bring, but basically, when you look at people's overall healthcare condition, it turns out only about 20% or so is actually related to people's actual healthcare services, going to the doctor, hospitals, things like that. The vast majority of people's health is related to these other, what we would call social determinants of health or social risk factors. So that includes, housing is a major piece of that, but also things like, your high risk behaviors, your social your social connections, and who, what kind of supports you have. And housing is, and I would argue that housing of all those social determinants is one of the most critical because, without a safe, stable housing environment, it compounds issues around employment, around your social connection. If you're constantly moving, education becomes much more difficult, and all these things we know affect your overall health. So again, at least in Access, this is a major priority right now, is how do you link housing to support the overall health goals. And then again, homelessness in particular, is a failure of a lot of those social factors. And so we also have a lot of focus right now, and there's such an integration between serious mental illness and homelessness and substance abuse and those kinds of behavioral health issues, that right now it's a major issue for us too, is how do we target our resources to, because we know housing is incredibly effective in addressing mental health and other behavioral health conditions.
Great. Well, I'm guessing that is exciting news to the rest of our panelists, that the state's Medicaid agency is thinking a lot about how important housing is to overall health and well-being, including mental health. And Terrance, maybe you can tell us a little bit more about how you see those factors being intertwined in your work.
Absolutely. So for me, I consider housing to be a cornerstone of healthcare. According to Maslow's hierarchy of needs, and an individual cannot focus. I can't pay attention to whether or not I'm going to my doctor's appointment or a dental appointment or my meds if I'm really worried about where I'm going to sleep, what I'm going to eat. So making sure that we're addressing the very basic need of having a safe place to sleep each night, that then goes a long way towards us being able to now engage the individual to start going to doctor's appointments. Let's get you registered with a primary care provider. Let's get you in for a psych eval. Let's talk about your meds. Are you taking them appropriately when you're supposed to? But having that foundation of a place for them to sleep. When I get them a place to sleep, I can get them cost-effective food. So now they're not spending all their money on fast food. I can get them beans, rice, get them bowls, plates, and stuff to be able to cook with. Now that I've got you in housing, we can start addressing all of your greater needs as a whole.
Excellent. Really good points there, Terrance, about how housing can be the foundation for addressing all those other needs. And I'm guessing Stefanie has a few things to say about that as well.
I definitely echo what Terrance was saying about how housing is really a foundation to build off of so many other things in somebody's life. So I would just add on to a little bit more of that. that if you go back and reference Maslow's hierarchy of needs, once your physiological, biological needs are met, the next one is safety. So I think it's important to also note that housing in and of itself is, can do a lot, but safe housing where you actually feel safe and you can actually rest and let your body actually rest and relax and rejuvenate does a lot for your physical health as well as your mental health.
And Carrie, how do you see mental health and housing being intertwined in your work?
Great question. I would echo what the former panelists said, everything from your ability to eat healthy food, your ability to feel in control and control who you live with and feel safe and secure. It's really a barrier that we run into sometimes when we're trying to get someone into a place where they feel safe and they can afford, especially with brain injury, where it's 0 to 60 happens so quick. You can be driving home from work and your entire life can change after a car accident or an attack or a stroke. So it drastically, immediately can change your financial situation. And so housing is at the top of the thing that you need, and sometimes the thing that is lost because of brain injury. So it's so important, absolutely, to our clients.
And you work for the Brain Injury Alliance of Arizona, and I think that we should talk a little bit about what the continuum of mental health looks like, and especially for folks like myself who don't work in the day-to-day world of mental health or behavioral health. What all is on the continuum of mental health, and how do things like brain injury and substance abuse fit into this spectrum of mental health?
Oh, that's a great question. So brain injury, and again, when we talk about brain injury, a brain injury happens every 23 seconds, but most of them will be mild, what we could refer to as a concussion. People will completely recover. But severe brain injury we like to say, turn up the volume on things that we all have as part of our personality. So if you're prone to depression, anxiety, or mental health challenges, it can turn the volume up on that. So it can be, addiction is also kind of mixed in there as both a cause and effect of brain injury. You're more prone to develop an addiction after a brain injury. And you can also, develop an addiction after. So it really is a cause and effect relationship there. So we're really lucky to be able to work on that statewide. We have a statewide opioid response team actually that was deployed from Access to look at the relationship between addiction and brain injury and how it destabilizes things like housing.
I would I'll admit right off the bat, I am not a clinician, but I've worked in this field for a long time. I think one of the big challenges we have with mental health, a good example, if we were all to go down to like the human services campus or, a homeless camp, we would all say there's a lot of mental health issues there. But until you really engage people, there's a number of reasons somebody's behavior might not conform, for lack of a better term, right? And I think, you just heard traumatic brain injury and brain injuries cause a lot of symptoms that people often associate with behavioral health. Erratic thought, ideation, like you said, anger management issues or emotional management issues. Drugs obviously can have a huge impact on somebody's behavior depending on what they're on and the effects of that and how they react to that. We heard people talk about diet. When you haven't eaten in a while, Snickers makes jokes about being hangry. That can legitimately affect how people, especially if they have diabetes or other chronic health conditions, obviously, those have effects. Developmental disabilities can often look a lot like, there's a lot of studies right now how autism patients sometimes get mistreated or misdiagnosed in crisis situations as having some type of substance abuse issue or mental health issue when they're engaged by the police because of some of the presentation issues. And so one of the biggest challenges, and this really goes to the housing programs and how we allocate housing resources, is until we can get somebody into kind of a safe, stable place to assess them and try to figure out which of these issues is at play, or even more complicated, sometimes there's multiple issues, right? It's substance abuse and mental health, and they're self-medicating for maybe traumatic brain injury or some other type of issue. And so until you can kind of really isolate the cause on two levels, one, to make sure you're providing adequate treatments and services, but then more importantly, well, for the housing standpoint, sometimes is unfortunately, or for lack of a better system, a lot of our housing resources are contingent on belonging to certain classifications or diagnoses, whether you're a veteran. You know, our housing at Access is primarily aligned around people with serious mental illness, with determined serious mental illness. So not just having a condition, but it has to be, you know, affirmatively diagnosed that you have this condition. Other programs are set up for domestic, you know, there are programs for people with brain injury, there's programs for substance abuse. And so kind of that's one of the biggest challenges in developing that continuum is how do we make sure that we're connecting people to the right services and to the right housing programs. And then again, the other thing I just want to clarify, when we talk about housing, one of the really important things to think about, especially when we're talking about people with these acute situations, is it's not just housing, it's supportive housing. So it's safe housing, the housing has to be safe, but the services, there also has to be services wrapped around those individuals to make sure that the housing is being supported. So in some cases, that's case management. It could be medication management. It could just be socialization, not just socialization. We'll talk more about that. But that service, that wraparound service piece is absolutely critical to the success that we've seen in these programs. And so again, as important as it is to have housing, it's also important to understand what the person's presenting or needs are so that you can also wrap appropriate services around that housing for it to be successful. And when you do, you have these outstanding outcomes that you see in the literature, you know, 90% success rates in ending homelessness, you know, 90% success rates in keeping people chronically unstable people in housing, you know, reductions in mental health, acuity, substance abuse use, all those things happen, but it really requires both the housing and the services to be integrated. So I just want to add that.
I think with brain injury too, it has to be, if the case, we don't have case management usually for brain injury, it has to be accessible to someone. If you have to call at 8 a.m. On Monday for a rent abatement, that can be hard for someone with memory issues or a cognitive challenge to remember. So it has to be accessible for someone, not just with a physical disability, but cognitive impairment as well.
Really good point. And I wanted to make sure that we dig in a little bit to the talk about wraparound services and what that looks like in practice. And I know both Stefanie and Terrance, you are doing that every day in your job. So how do you work with people, and what kind of services do you provide? And can you tell us a little bit more about what you've seen and be successful?
I can
Stefanie.
go. First, I want to echo, actually piggyback off of what David was talking about with those wraparound services and how important that is, and point out that recovery is possible for everyone that we're serving with any mental health needs, but it takes that long-term stability to get there. So I also just want to advocate that long-term or permanent housing subsidies are key in all of this as well. And then to answer your question, Serena, at Native American Connections, one thing that we do with housing is that all of our communities are project-based, meaning that the apartment community is, everybody there meets the rental criteria for being homeless or chronically homeless, depending on funding. So we're also staffing those 24/7. So our staff are seeing people day in and day out, and you really get to know people when you're seeing them every day, all the time. There's some, staff that people are able to really predict behaviors just based on the historical knowledge we have with them. And having that historical knowledge can really help in the service delivery piece of that. I'm also going to shout that case management does not happen in the office. Case management can be a conversation over coffee in the courtyard. It has been a walk to McDonald's to go get a cup of coffee or an ice cream cone. It is doing home visits. Somebody's home and the condition of their home says so much about what's going on in their life. And you can really be very proactive in a lot of landlord issues when you're doing home visits, because you can go in there and see, are all of the cabinet doors on in the kitchen? Does it look like there should be, if there's 3 people living in a unit, does it look like there's 3 people living there or 10 people living there? You can be really proactive in all of these things when you're doing home visits and use your eyes. Just use really all of your senses when you're doing home visits. So I won't monopolize all of the time. I'll give Terrance, let you answer too.
Really great point,
right.
though, that case management doesn't happen in the office. So thanks for sharing that. And Terrance, I know you are of a similar philosophy.
I am definitely of a similar philosophy. We have approximately 150 site-based units, in addition to close to 500 scattered sites. So we do access housing, we do COC, HUD funded housing, we do it all. And none of our members typically come into our office. All of our case managers deploy out to the members. We are, even in our job description, it's 85% of your services will be provided in the members' homes in the community. Well, let me start over. We are blessed to be able to offer integrated health care through our conglomeration of facilities. We can offer everything between medication-assisted treatment services. We can do behavioral health. We can do health and wellness. We have a gym. We have a lot of resources that we're able to deploy. But it all starts when we get our member. We're going to give them a thorough assessment. We're going to see how they're doing in all areas of their life. If medical is the need, then we have doctors here. If it's psych, we have psych here. If it's something that we need to refer out, if it's a service that we don't offer, then we'll definitely do that. But each individual needs to receive a thorough, comprehensive assessment to see how well they're doing or where they're deficient in any areas. So that way we can begin to wrap them with all of the layers of services that they need. Just the fact that they were homeless alone brings its own bundle of fun. And if anybody who knows me, anytime something is frustrating or trouble or hard, I just call it fun. But any individual who is receiving any kind of behavioral health services, or even if they weren't prior to homelessness, all of their mental health concerns are definitely going to be exacerbated strictly based on the fact that they were homeless. The trying to survive day to day, where am I going to find food? I don't feel safe. I've been assaulted. All of these things add up. So even when we first put a person into housing, it's not like, hey, yeah, you have housing and now everything is fine. We generally tend to see a decline in the person's functioning. So that's when we try our hardest to wrap the member with all the services that we can, that A, they want, and B, we can assess and see that they possibly need.
And I just add, just to Stefanie and Terrance both brought this up, but it's really about having an individualized service plan, not just a generic, so as Stefanie said, that may mean you have to deliver services in their home if they're not comfortable with coming to an office or to a central site. As Terrance said, it's really customizing that service plan around their specific needs, not just a generic get a job, right? Or, take your medications, go to the doctor and get a job or income. It's not that simple. It's really customizing it to the individual's need to make sure that it's meeting them where they are. And when you individualize it, you have these incredible outcomes that we've all experienced.
And how would you do that? How do you individualize these services to meet what each person needs?
I'll defer to Stefanie and Terrance. They probably have a ton of lived experience doing, Carrie too, have lived experience doing this. But it's really, again, it kind of like they already started to explain, and I'll let them go because they know way more about this than I do. But it really is just really knowing the individual and meeting them where they are, and with the assumption that you don't have all the answers, that you need their participation in it. Really recognizing member choice, we would call members as an access, but client choice or the individual's choice and kind of what they want to work on, what they're ready to work on. Not just assuming that sobriety is the first goal for everybody. It's really meeting the person where they are. And like I said, I defer to the rest of the group who are much better at this than I am.
Anyone else want to hop in?
Yeah, so we do have various assessment skills that we use. We use the Ansel Casey Life Skills Assessment. We use the full service prioritization decision assistance tool, the SPDAT. And then we also use the Access Comprehensive Assessments that we're doing. we literally want to find out every area of this member's life. But as David said, the most important part of it is the clinician's ability to build that rapport with this member. I'm not your probation officer. I'm not the police. I'm an individual who's here to help you. And once you develop that rapport and you start building that trust, it does tend to go a lot easier. You're not pushing the horse. You're just walking beside your member towards helping them achieve their goals that they would like to achieve.
There's been a lot of movements too in going towards person-centered planning. We're with someone sometimes for a lifetime after their injury as they transition. So we're referring out to Terrance and Stefanie's program, and then we're with people as they transition, throughout the community. So it really is just letting them be in control of their plan, really utilizing all the wonderful resources we have in the community around harm reduction and, being able to pull in those different pieces. And it is really also addressing those things that you don't think are things. Like we have a pet care fund. We track gaps in services. So when someone needs something and we can't refer them to it or can't connect them with it, we track gaps in services. So we have things like pet care funds. We have transportation pass funds that anyone with a brain injury can apply for. So just really addressing those gaps as part of it as well.
And Carrie, are
I'd
those
also
things?
add.
I was just going to ask Carrie if those things are just good for people with brain injury, or what do you think?
They are for people with brain injury, but remember the spectrum of brain injury, it's acquired brain injury. So stroke, concussion, TBI, and a lot of our vulnerable populations, people who have been homeless, incarcerated, they're going to qualify for them. So when there's no bad referral, send someone over. Our services are free. So, and we also are connected with wonderful community resources like Terrance and Stefanie's.
I would add in that training on motivational interviewing and providing trauma-informed care is essential to people providing these services. And can I answer or just respond to a comment in the chat?
Of course, please, because we want people to be contributing to the conversation, and that's how they do it in the chat.
So I want to respond to Tom Kelly. You made a comment that it'd be great to have a panel member that has actually gone through the system to share their lived experience. I totally agree. People with lived experience have to be at the table all the time. They have to be at the table and not tokenized either. That's important too. One thing that we do at Native American Connections is when we are thinking about who the best case manager would be for a client, if somebody is struggling with substance use, let's match them with a case manager who has that experience as well and has gone through treatment and is in recovery. That might be the best fit there. Same with mental health or domestic violence. Always try to match a veteran with a veteran. That's peer support in that way is so important. So I do want to recognize that is something that I don't think we might talk about all the time, but it does happen in practice, and that's just something we can be better about at making sure that the right people are at the table.
And there is a lot of literature around the again, a well-trained peer in a lot of cases, somebody who has lived experience with any of these issues, mental health, substance abuse, homelessness, are often some of the best providers of these supportive services. And there's a lot of literature on that as a best practice. And I know a lot of our local providers really implement that as part of their care teams and their service planning.
I think family peer support too doesn't get enough attention, or sometimes particularly with brain injury or substance use, where a family peer support is really needed. The person might not want or be ready for help, but a family peer support can be great.
And that's kind of a segue. I hope I didn't cut somebody off, but that's a good segue. When we talk about these supportive services, a lot of them are clinical. We're talking about medication, or I would consider clinical, but medication, or that a case manager or maybe a behavioral health professional might deliver things like case management, things like med management, or medication adjustments and things like that that come from the clinical teams. Employment, training, and all those things can be kind of a institutional type of provider. And from an access perspective, there was a question earlier about like, how does somebody on Section 8 get these benefits? A lot of these are Medicaid covered services, and can be billed by a behavioral health provider if it's included as part of their case planning, of that individual's case planning. But a lot of the services that we're talking about, and again, I'll defer to everybody else here, but we're also talking about a lot of soft services. And so you heard reference to like the importance of family peer supports and things like that. A lot of the work that's done is not just on these clinical things, it's also socialization and life skills and trying to find ways to help the person adapt to their new living situation. You know, how do you take somebody out of a homeless community where they may have developed some supports and resources, and you've now put them in housing where they have to develop those resources again, you know, meeting their neighbors, working with landlords. They didn't have a landlord when they were homeless. You know, where do you get food? You don't dumpster dive anymore. You need to, or go to the St. Vincent de Paul dining hall. You need to actually, you know, work on budgeting and all these types of things. So, and a lot of those things don't come from clinical support. They come from social support. They come from peer support. They come from, you know, learning, again, just like all of us rely upon, right? I always test people. How many of us have ever taken a formal life skills class? Probably very few of us, unless we maybe took health in 10th grade or something like that. The vast majority of us learn that from our community, right? Our neighbors, our friends, you know, our family, you know, well-meaning people who, you know, recommended we change our hairdo, whatever it was. That's where we got those life skills trainings. And again, a lot of those same issues are at play when you're talking about these supportive services people need. It's not just the clinical piece; it's this bigger wraparound community piece as well.
I also wanted to hop in. I'm going to turn this to you, Terrance, in just a second, but we're getting a bunch of questions in the chat, which is great. So please keep your questions coming. And to answer a few questions, yes, we are recording this session. I have a feeling, just judging that we're halfway through and we've got so many questions coming in the chat, which is great. Please keep them coming. We are not going to be able to every single question, but we will get to as many as we possibly can. And on the services, the soft services, we had a question come in the chat about how well prepared is the system in responding to the physical needs of individuals who are aging in place but are not all tax eligible, so not eligible for the Arizona long-term care system. And Terrance, I know you had an answer to that, and you might have some other comments too. So over to you.
Okay, so I just wanted to address the lack of peer. Full self-disclosure, I am a peer in just about every way you can possibly imagine. My name is in a homeless management information system. I actually came through the system being provided services. I am a survivor of just about every social services genre you can think of. So the way I choose to approach services is based on what worked for me, and that was, I'm an individual. I am not the same as everybody else. So my needs were pretty severe, and I had a lot of extremely dedicated, empathetic individuals, which helped me. So that's what I instill in all of my staff to provide the services to our members. I did also address the lack of, the individuals who are in housing and they need a higher level of medical care, and we are not able, they're not qualifying for All-Tex at this time. I have quite a few members that it's a bit of a challenge, and what we've done is we started coordinating with the members' primary care providers to be able to get home health services in there. So in addition to my staff that are going out and meeting with the members, we have healthcare providers that are coming out, helping with meds, helping with bathing, helping with food. And then all of this information is still being gathered, and we keep reapplying and appealing to All-Tex to get the individuals approved based on the notes that are being completed in relation to the services we're providing the member. And then there was one last one I wanted to address. It says, Ms. Rochelle Fink put, when our tenants are having psychiatric episodes, we're told to call the police. Is there someone we could call instead that could address the psychotic the psychotic episode. One of our selling points for landlords, as I said, we have about 500 members in scattered site. One of our greatest selling points is if our member is at your property and they're not doing well at all, you don't have to call the police. You're not on your own. You can call us. My staff will deploy. I was just meeting with my supervisor about getting overnight and weekend staff as well. So my staff will deploy, even in COVID. It's unfortunate, but we give them tons of PPE. Here's a mask for you, for the member, face shields, some hand sanitizer, and we're still deploying because COVID doesn't stop our members. So we're the ones who go out there, and if we need to call out the crisis team, then we'll call out the crisis team. We'll help coordinate that. And as a housing provider, I think that's really my job. That's what we're here for, is we're to help the member. Because if you're just calling the police every time and the member punches a police officer, now they're going to jail, they've lost their housing, and everything's downhill from there.
Thanks for
I think
sharing.
it's really important to establish relationships with clinical teams as you see them. That's one thing that I have some staff on here, they will tell you, make sure you talk to their clinical team, have an on-call number. If they're part of an ACT team, have that on-call ACT number with you all the time. Know how the mental health clinics work. What is the structure there? I think that's really important. That way, when you see something happening, you see, oh, this person might be decompensating, intervene right away, so we're not waiting until a full-on psychotic episode happens where they might be putting their housing in jeopardy. And to address the all-text thing, David and I are actually working separately out of this, and we are hoping to soon provide training to, this little niche of housing providers, housing case managers, about all-text, specifically on all-text applications. So you can keep your eyes open for that soon.
Exciting stuff on the horizon. Thanks for sharing, Stefanie. And we've had a number of folks ask about how to connect with our panelists and resources, like how you could find out more about this all-text. We will be out a follow-up email. I know Carrie had sent some excellent resources to me this morning. So I am going to make sure that we share those resources along with information on the all-text training. I'm seeing enthusiasm in the chat for that already. So we'll make sure to share that information. Also, we've had a number of references to the crisis response network. 211 is statewide. So if you are looking for a number to call in Tucson, it is 211, and that is true across Arizona. And so we'll send out some follow-up resources as well. I wanted to go back to what Terrance was saying about COVID, because we've made it almost 40 minutes into a webinar in October 2020, and we haven't talked about COVID, which is refreshing, but it is it is the reality that we're in right now, right? So I wanted to make sure that we talked about how the pandemic is affecting both mental health and housing, and how you all are seeing that show up in your work. And I'd love to have all of you just weigh in with your thoughts.
COVID for us, for the brain injury community, has been interesting, because for some, they like to say that they were already a little bit quarantining in their house before COVID because of neurofatigue. Maybe they couldn't do things after work. They couldn't go to a new venue to hear a concert because they weren't comfortable navigating it. So for some of our clients, they're kind of like, welcome to our world, life after brain injury. But for others, it is devastating because they had a routine, they had a pattern, they had social supports, in-person support groups. So we've gone online, even the peer support, like veteran peer support, and we have an interpersonal violence liaison, thanks to a contract with Mercy Care. We were able to deploy those still online and now a little bit in person. But we're also concerned about we talk a lot about those that we've tragically lost to COVID, but also survivors of COVID have unknown neurological complications that we're still unraveling. So it could change the face of the client that we all see down the road, in addition to making service delivery more complicated right now.
Really important food for thought there. Thanks, Carrie. Does anybody else want to weigh in on what you're seeing with COVID?
Yeah, I mean, I think everybody's kind of waiting for the shoe to drop. You know, there's been these eviction moratoriums and things like that. Again, clearly, you know, social isolation resulting from COVID and is not a positive. So, you know, we've been working with our housing providers to make sure that, you know, they're increasing wellness checks and those types of things, just to make sure, you know, there's no, as Stefanie was saying, you know, there's no issues boiling or those types of things. You know, the other issue is, we want to really make sure, and we've been trying to communicate this as well, just because there's an eviction moratorium means they can't kick you out, but they can absolutely start the legal proceedings to kick you out, and they still can kick you out for cause. And so you know, we want to make sure that people are paying their rents. That includes tenant portions of rents. So you know, in a lot of these cases, the housing subsidy only covers a portion of the tenant's still responsible for a portion of their rent if they have income. Usually it's 30% of their salary, or of whatever income they have. And this would apply not just to access housing, but this would apply to Section 8 programs. Any of the other federal subsidized programs usually have this income requirement. The subsidy program may be paying their part of the subsidy, but again, if the tenant's not paying their portion of the subsidy, there could be potential, you know, eviction based on that when the suspension ends. And then, if again, the other thing we're worried about is that if somebody hasn't been paying rent for a period of time, you know, those are accruing penalties and fees and all those other negative, you know, pieces. So that when they finally do have to pay rent, it won't just be, you know, a couple $100s, it could be thousands and other fees. So anyway, we've been trying to make sure our housing providers have been following up on that, working with Terrance and, you know, his teams and the other teams like his across the state. But that's just something, if you are advocating for clients or assisting people, you know, be aware of and make sure that's being taken care of. In some cases, you can change the person's income. You know, if they've lost a job or there's been some disruption of their benefits, you know, you can tell the housing provider that they now have zero income and can't pay their share for permanently or for a period of time. Again, we need to make sure that's being done so that, you know, the rents are adjusted and the subsidy can be increased. But really kind of paying attention to people in these situations is critical in these months. So.
And if I can just add, as far as evictions, we have a utility fund. Don't get too excited because it got depleted this summer. we have a utility and rent fund, and we only saw 10% of the requests that were COVID related. The rest were still life with brain injury. Like, I can't work because I'm you know, working through a series of brain surgeries, you know, at the local you know, banner. So they're normal. We were still seeing the normal barriers to housing for our population. One of our cases was we had a veteran who had a wonderful livable house, had flood damage, but she couldn't connect the contractor with the insurance and do all the things in sequential order because of cognitive impairment. And so they couldn't live in their house. So we weren't really seeing, from the brain injury perspective, a huge increase in COVID evictions yet, or COVID related problems yet.
Still waiting to see what the future has in store for that. And Terrance or Stefanie, I don't know if you wanted to weigh in or if we wanted to go back to some of the audience questions.
Sure, I'll weigh in quickly. COVID has been fun for us. It took a lot of front end work to get it set up, but after the initial legwork, we're actually able to encounter more members. We were able to get funding. We bought toilet paper to distribute to our members just in case. It's been a very interesting year, but I think personally, I enjoy it. And I know my staff are really happy to be able to answer the call to all of our members. We've moved most of our services through the graciousness of access. We've been able to provide a lot of services telephonically. But like I said before, if we work in social services, everything can't be done behind a desk. So when you have to deploy, you have to deploy. So we got tons of PPE, and it's really been it's been an interesting year, but I think we're doing okay with resolving that. As far as David was saying, if our members lost income, we do an income update. Now that they're required to pay 30% of their income. 30% of zero is zero. So if they lost their job, oh, great, now your subsidy covers your portion. We'll see how it all balances out at the end of the year if we're overspent, and I can tell my CFO how much money we lost this year. But other than that, it's been a fun year.
I think everyone might start using your term "fun" to describe some of the surprises that this year has had in store for us. I wanted to get back to one of the questions that had come in from Cynthia Hernandez, asking, because we've had a few questions pop up in the chat about how people actually access these housing programs. And is it through a coordinated entry point? Is it through a general mental health clinic? We've also had a couple of questions just asking about what kind of housing funding there is for just general mental health versus the seriously mental ill population, and what that looks like. So we might talk about the entry point with Terrance or Stefanie, and have David talk a little bit about what funding looks like for housing.
Okay. We provide wow, this is a really big topic. So there are things called continuums of care for housing. There are actually 3 of them in Arizona. There's one for Maricopa County, one for Pima County, and the other 13 counties are considered balance of state. Each continuum generally has their own coordinated entry system of how you would apply. Here in Pima County, Arizona Complete Health actually participates in our wider continuum. So I myself, with all of these grants and all of these fundings, I am not allowed to add any person to my program. If I have an opening, I let the coordinated entry system know, or I let Arizona Complete Health know, and they send me the next individual that's on their list. All of the housing is based on vulnerability, so it's not first come, first serve. It's who's in the highest need, who is the individual with the highest need of housing, who's doing the worst in life. And so again, I can't accept any direct referrals. We always go through all coordinated entry systems. And that also holds true for the counties we serve in the balance of state, which includes Pima, Cochise, Graham, Greenlee, and Santa Cruz counties.
And for Native American connections, the majority of our housing is also continuum of care HUD funded. So we as well would go through coordinated entries for our units as well. We are a closed entry point for people who are Native American. So if you have a single Native American that you're working with, you could refer them directly to us. That doesn't guarantee them housing or expedited or anything, but it is the entry point into the coordinated entry system. We also have some units that are contracted with the Regional Behavioral Health Authority. So there's some units, we have some community living program units and some scattered site units within our NAC portfolio. So we would get direct referrals from the Behavioral Health Authority for those particular units.
Stefanie, did you have, should we show some photos from one of your, okay. Let me, hopefully this works better than when I was trying to show the video earlier. All right. Is that up on screen?
So
we just see the
no, we can see your files.
Oh, well, that's fun. At least maybe this folder is well organized. Okay. See if okay, here we go.
There we go. So I have just 3 pictures really quickly, and things that I want to point out is when we're building, we want to make sure that safety, we've asked our residents in the past, what do you like about living here? What's important to you? And every single time, by far, the first thing that comes out of people's mouths is safety. So all of our properties are very safe. There's a single point of entry. So this is the lobby that you would walk into at Camelback Point. It is much more, this is when we first opened, so it is much more lively and decorated now. But there's somebody at that desk all the time. There's usually something going on. There's at least a friendly face to greet you. And if you need to come talk to somebody at 2 o'clock in the morning, there's somebody here that's going to talk to you or answer the phone. And then the next 2 pictures are of a unit. So you can see, if we switch over, that the units, they're fully equipped, and when they move in, we have a move-in kit for them. So they have all of their dishes, cookware, some basic furniture, linens, towels, everything they need to really get started. We want everyone to really feel at home and that they're safe. This is their own place, and they attach to their apartments and get comfortable. So the picture you see now is the kitchen area. And then the next picture, I believe, is like you can see like the living room area and bedroom. And a lot of what we build, we also take into consideration client input. So there's some safety features on the stove. You can't turn the stove on without turning the timer on next to the stove. I know for a fact that has prevented some fires in our apartments. And then if you go to the next picture, you'll see that it's actually a pony wall, not a traditional 1-bedroom style for the bedroom, and it just makes it feel more open. So if anyone is in the development arena or, has the position to give feedback from clients is very, very important. And a lot of little touches that you see here are directly from client feedback that we have.
What a fantastic example of involving people who are going to be living in these units, in the design of the units, and helping them, making sure that it works for them. And I just wanted to share that I also love that when people walk through your doors at Native American Connections, you refer to them as unsheltered guests. And I just think that's so amazing and humanizing. And I wanted to make sure that we had a moment to see those pictures and talk about that. So thanks, Stefanie, for letting us take a look at Camelback Point.
Can I go back and just finish just a little bit more on accessing housing?
Yes, please.
A lot of the questions I know are focused on access as housing. Again, we have about 3,000 units year to year. That includes site-based housing as well as scattered site housing. The vast majority of that, per the state law that funds those, are for people determined SMI. We do have a small amount that's available for people with general mental health. Those funds are administered through the REBAs. And so, contacting the REBAs and following each REBA has its own process determined. As Terrance said, in the southern counties, it goes through AHCCCS directly. They make those referrals. In Maricopa County, I believe they coordinate with the coordinated entry system for the general mental health referrals. And in the north, I believe they go through the clinics or through the REBA. But what I would say is, and this is one of the really hard, complex things, and Terrance alluded to it with the COCs. The COCs roughly mirror the general service areas that Access uses for the REBAs. So all areas should be covered by a continuum of care and have housing available through the COC program as well as through Access. But one of the things I'd recommend for people pursuing housing is get on any program or wait list you can get on, because we're running a couple thousand people wait list on the Access side. The COCs have hundreds or if not thousands of people on their wait list. Section 8 programs sometimes have set-asides and priorities for people with mental illness. The Veterans Administration has vouchers and subsidies for people with mental health and other disabling conditions. And so you got to be really patient and persistent, but but I would pursue all those avenues, not just one, and make sure you're following through with whatever those processes are. And that's another place where case managers or supportive services can come into play. When we talk about permanent housing, it's not just in the keeping them in the housing, it's getting them to housing as well. So it's that transition. Terrance and Stefanie talked about transitioning somebody from the street, into the housing, helping them with paperwork, getting documentation together, doing all those things you need to do to get the person to the housing. The last thing I would say on housing right now is when we talk about housing availability, we talk about the subsidies that are available, but we haven't talked about the availability of actual stock to put people into. And to my knowledge, every single community every single city, town, or jurisdiction in Arizona right now is really struggling with the lack of housing stock. Prices have gone up. Vouchers sometimes don't even cover the cost of the housing. They're going up so fast. I think we have a 2%, 3% vacancy rate across Arizona right now in rental housing. So one of the big barriers is even when people have vouchers, trying to find places for people to deploy them or to use them or to sign up for them is really hard. And because the market's so tight, landlords don't have to take vouchers anymore. Why take a voucher and all the baggage? And, to be very frank, why take a client with mental health when I can just rent to the next person off the street who may not have those issues and those barriers? So, there's a real lack right now. I think on some of our programs, we know it's taking, somewhere between 90 to 180 days to get people from the street to housing, between not only the service needs, but literally just trying to find housing to put people into. And it's even worse in rural areas where there's literally no housing stock, and the housing stocks that's there may not even qualify as habitable for the purposes of vouchers and things like that. It's trailers and places not substandard, but it's not traditional housing units like apartments that are usually what people rent. Sorry.
That sounds like that could be its own 1 hour online conversation. So maybe that'll be discussion part 2, because I think that's an incredibly important topic about housing inventory. I wanted to, we're getting near 11 a.m. So I wanted our last question for the panelists to be about equity, because we know that mental health and housing are also disproportionately impacting particular communities. And I wanted to just have you end with some final thoughts about how do we weave equity into this work and make sure that everyone has an equitable opportunity to have good mental health and to be stably housed. So I'll start, Stefanie, if I could have you start and close this out, that would be great.
Sure. So to build equity into our systems, it's an absolute. The data, the numbers don't lie that there's homelessness and housing issues very disproportionately affect Brown and Black communities. Our local data shows that. So we need to talk about it. It needs to be at the forefront of discussions, and we need to weave that into our systems. A lot of policy doesn't allow for nuances. We're the ones in the community. We're the ones that know our community. So the grassroots in me wants to advocate that everybody needs to be involved in policy, speak up. We need to make some change and vote.
Thanks, Stefanie. Carrie, how about you?
Well, for us, for equity is getting people to the right services. So we are able to be anyone's partner in screening, helping them deploy quick and easy screening tools when you get to the point of supportive housing. And then we also are, since we interact with the healthcare system, we are in the eye of the storm as far as healthcare inequity. And you're actually going to probably be hearing a lot about that. The Alliance is part of a nationwide network, and we are together as a network looking at how people find our services. So people can self-refer, you can request services for yourself or someone else anytime, or you can be referred by a hospital system. And we're looking at how people are finding us. Are they getting a referral from the healthcare system, which they should, from hospitals, or are they self-referring and looking at where some of those inequalities exist? We are deeply concerned about the lack of maybe people of color getting to services that have life-changing effects, like after brain injury, like speech therapy, occupational therapy. So we are committed to addressing that and looking deeply at where we can be a part of the solution as far as healthcare inequity. So you'll be hearing a lot more on that. But screening, helping people unravel those unknown brain injuries that are really a barrier because they're, presenting with behaviors and different things that are really a barrier to them being able to maintain housing and maintain themselves.
Great. We'll make sure to include your contact information in the follow-up emails so people can hear about all of the exciting things that you have coming up. Thanks, Carrie and Terrance.
Well, as I mentioned before, there are policies in place that dictate how an individual gets into housing, and it's based solely on their vulnerability. In the meantime, as Stefanie alluded to, we need to work on improving our policies on how we're actually screening individuals, which individuals we're reaching out to make sure that they are included in the count, that they are being assessed. Here in Pima County, we actually just started a diversity, equity, and inclusion committee, which is part of our continuum of care, which is for the sole purpose of addressing the inequalities in the homeless system and making sure that we're getting that outreach to the individuals we have systemically missed in the past.
This is a huge issue for access. There's a health equity work group that's been holding public meetings over the last couple of weeks. I'm not sure if they have any more coming up. Within housing, one of the things we're working at is trying to get better data and information. Standardizing some practices so that we can get a better sense of, make sure that those systems are being applied fairly, the referral systems are transparent and things like that. So we're doing things like that to try to get a better sense of the numbers and the data, but it is a major issue for us, and it's a major concern for housing as well. And it goes back to the services. I think, Native American Connections is a perfect example, but, making sure we're providing culturally appropriate services or equity-based services that, again, goes back to that individualization and making sure they meet people where they are. And sometimes those again, back to the social issues, sometimes those barriers aren't just medications and case management. It may be culturally based, or it may be, racially based. And we need to make sure we're meeting people where they are. Again, so that those services can be effective.
Well, I just want to say thank you to all of you and your organizations and agencies for the work that you do. These are huge issues, and I'm so glad that such thoughtful, caring people are at the forefront of making sure that we're talking about this two-way relationship between mental health and housing, and figuring out how collaboratively we can solve these issues together. I am really grateful to all of our sponsors for making this kind of conversation possible. My apologies to Mercy Care for my own IT difficulties in showing that video earlier today. That is entirely my fault, not theirs. And I will make sure that we send out the recording and a bunch of resources to everyone who registered for this webinar. But my most appreciative thanks to the Arizona Housing Coalition for co-sponsoring this, and to David Bridge, Terrance Watkins, Stefanie Smith, and Carrie Collins-Fadell for being our expert panelists today. And thank you to the audience for really participating, asking some great questions, and being a part of this incredibly important conversation. And look forward to hearing more from all of us about upcoming conversations and continuing to tackle mental health and housing. And take care, everyone. Stay safe. And like Stefanie said, be sure to vote.
Thank you all.
Bye-bye.
Thank you, guys. Thank you for having me.
Thank you.